All. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So today is an interesting study. This is the largest study from UK for the boosted individuals. So the basic objective of the study was the following. Authors said that we know that even after the boosters, and here they used a word that they used a term called, they called it initial booster. So we had the primary series, dose 1, dose 2. Now this is the initial booster, that means booster 1. There may be more, so these will be initial booster, first booster, second booster. So their term is initial booster. So they said that there were people even after the booster who became severely ill. And the question became, who are the folks who are still becoming severely ill? And what is the reason? What are the comorbidities? What are the factors that are responsible that even after boosters, folks are becoming severely ill or dying? So they said that UK's, let me share my screen as well. So this is the study, October 15. So they said the UK's Joint Committee on Vaccination and Immunization reached out to the authors and said, can you help us understand who are still at risk of the severe disease even after the boosters? So that is the study. And authors say that to their knowledge, this is the largest study that has tried to answer this question. So that is a question that we are going to look at. Some general thoughts to keep in mind. The initial primary series, this is UK population. So initial primary series, people had AstraZeneca, Oxford AstraZeneca, or they had the Pfizer. Then during the booster time, people had Pfizer or Moderna. That's one. Secondly, it seems like, at least from this data, Moderna performed better in protection compared to Pfizer, almost double better than Pfizer. Then, another interesting thing that is in here is that the protection, even after the booster, goes up to 9 or 10 weeks. Although their study time is from December till February, so it's just 3 months. But they're seeing protection to reduce. And we have seen that before as well. And the authors say that we have seen this and we observed the same. We have seen this in the previous studies and we observed the same behavior, which kind of makes me a little unsettled that do we now need to give every 2 months a booster to provide protection? Then there is another thing which, of course, the authors were asked by the government to provide the study. So they were a little delicate in their messaging. So at one point, they say that we need to figure out our approach to enhancing the protection. So you have to be kind of a little smart in looking at their words. Of course, you are smart. You have to kind of clearly look at their words. So instead of saying protection, or they use enhancing the protection, which is equal to boosting. So they're saying that we need to figure out other mechanisms, other approaches for enhancing the protection as well. So that's an interesting study. Let's look at this study. The question that I would like you to have in your mind is that when people are boosted and they still are becoming severe, what is the characteristic of this group? And there was one more thing, and I'm just going to say that too before we continue more in detail. There is an interesting chart in here. The figure number 2, bottom right chart, and I'll show you here as well. That chart shows if someone was previously infected and then started having vaccines and finally had booster. This is a study of boosted individuals. Then the distance between the infection to booster, the more the distance between them, the better the protection. So far so that after 9 months, so if somebody had an infection and their booster came 9 months after the infection, then they had the most reduced risk of becoming severe. And I do not have a good answer for what is this mechanism that says the farther away an infection to booster time is, the better the protection. So let's look at that together and then we'll discuss more. So here is a study. I'll come back to this study as well. Let me just quickly show you the references, other references. So here, this is drbeen.com. There is a link in the description which gives you one-time fee access at a very low price. This is the study that we're going to talk about. And this is the vaccine scheduling. The reason I brought up CDC's vaccine schedule, I wanted you to kind of give a look at other vaccines and their boosters. Because in case of SARS-CoV-2, it's not even the yearly booster or 6 monthly boosters. From the studies, the data that is coming out, that shows almost every 10 weeks, which is 2.5 months. And considering CDC's director, Dr. Rachel Walensky, becoming infected 1 month after the bivalent booster. And again, there are folks who are saying that, hey, she did not become severe. That is the benefit of the booster. Fine, but still within a month of the booster. So the question is, if somebody has these factors that we're going to talk about, then are they even protected for a month or not? So that's a different discussion. I want you to look at this schedule as well. And let's now look at the study. So these are gifts for humanity. They're continuing, and let's start. This is a large UK study. It seems like my pen is not working, so give me a second. All right, so my pen has become somehow non-functional. Okay, so I'm going to just use mouse. It will not be the best marking, but let's go with that. So their objective, identify the risk factors. Let me change the color. Now they called this booster as the initial booster. What they did was, it's a prospective cohort across all 4 UK nations. And they compared, as I said before, Oxford AstraZeneca plus the Pfizer, then as a primary series, and then Pfizer plus Moderna as the secondary or the booster, initial booster. This study was done from December 2021, so December 2021, last month, Omicron time, to February 28, 2022. There were 16 million people who had the primary vaccine. And there were 13.8 million people who had the booster as well. The authors had the data available, and what they saw was that those who had the primary vaccine, 0.4% of them became severely ill or died. And those who had the booster, 0.2% of them became severely ill or died. Once again, the time frame is about 10 weeks. So they said that the booster reduces the risk of severe outcomes. Good, fine. Booster reduces the risk of severe outcomes. We have done this discussion many times in the past as well, that anytime you give an exposure through a booster or through an infection. Of course, I do not recommend infection. There is going to be the immune system that will ramp up and that would start making antibodies, and that activity will produce the uh, antibodies that are there to protect. And then they would start waning. So, the benefit, how much was the benefit? The benefit was overall 8.8 events being the severe cases, either hospitalization or death. 8.8 per thousand person years to reduced to 7.6 per thousand person years. There was 0.4 events per thousand person years benefit. I think that's a very tiny benefit, but still, that is the benefit. Now, what did they see? So, here is where I need your attention. Despite initial booster being the first booster, because one of the recommendation of the authors is to give more boosters. That's why they're calling this initial, and they're saying we should have subsequent boosters. Despite initial booster, older individuals who are 80 or more than 80 years of age, compared to younger individuals, and the definition of younger is 18 to 49 years of age. So when you compare these two, both are boosted groups. The older individuals had an adjusted rate ratio of 3.60, 3.6 times more incidence of the serious cases, or adjusted rate ratio is the right term. And the 95% confidence interval, 3.45 to 3.75. So that many folds higher risk. So first factor, age, more than 80 years of age or 80. Second factor. So this is, we're talking about boosted individuals. Second factor, 5 or more comorbidities versus none. So if somebody has no comorbidities, a group, and they're boosted, versus another group that has 5 or more comorbidities and they are also boosted, then the difference between them, look at the difference. Adjusted rate ratio is 9.51, 9.5 fold difference, comorbidities. And the range, 95% confidence interval, 9.07 to 9.97, almost 10 times difference, 9 to 10 times. Then, sadly, men as well, just being a male, is a risk factor. So adjusted rate ratio is 1.23, not a very large difference compared to women, but 1.23, and the 95% confidence interval is 1.2 to 1.26. So despite a booster, older individuals still have a high risk. People with the comorbidities have a higher risk compared to those who didn't have the comorbidities, males. Then they called out certain groups, especially immunosuppressed compared to those who are not immunosuppressed, or immunosuppressed who are taking medicines. For example, they had organ transplant or some other reason to take immunosuppressants, compared to non-immunosuppressed, 5.8 ARR, and the range 5.353 to 6.09. So that's a very high range as well. So if you see, highest range is comorbidities, then is immunosuppression, then is the age or chronic kidney disease. So if you see here down, chronic kidney disease versus someone without chronic kidney disease, 3.71. And the range is 2.9 to 4.74. So I'll keep repeating because people would skip around in the video and then keep asking that, what were you talking about? This is the boosted individuals, all of them, but despite being boosted, what were the factors that were still making people severely ill? One interesting takeaway was that previously infected and then boosted, and that boosting more than 9 months between the infection to booster, 9 or more than 9, they actually had a reduced risk. So to me, this also means that infection being one event, one exposure, then primary series, two more exposures, then booster, one more exposure, so four exposures. So here, adjusted rate ratio is 0.41. So it actually cuts it in half, the chances of the severe disease. And the range, look at the range, 0.29 to 0.58. This is previously infected. And I'll show you, actually, I have the picture of that graph over here. This is a very interesting graph. This is the graph. If you see this graph here, it says history of SARS-CoV-2 infection. And this is the box here, adjusted rate ratio. Check this out. No previous infection. So we are still talking about boosted. Let's say they are the reference here. Now, infection and booster, the difference between these two events, or these two, let's call them events, lesser than 3 months is almost near 1. 3 to 5 months, slightly lesser than 1. Then 6 to 8 months, even more lesser than 1. The lesser it becomes, the reduced the risk is of becoming severely ill. And so when there is a difference 9 months or more between the booster and the infection, that has, in this whole study, that has the best reduced reduction in risk. And so, what do you think that what could be the mechanism behind this? Okay, so continuing, this is their figure number 1. If you wanted to see it, I'll go to that as well. Then if you see here, this is another figure, and once again, previous history of SARS-CoV-2 infection. I know it is probably small, but the point is they have a table as well where they say previous history of SARS-CoV-2 infection. And as you can see, as the infection time and booster time difference changes, the percentage continues to become lesser. So lesser percentage is actually meaning better or reduced risk. So no previous infection and boosted 97.4%. Then booster and infection distance 0.9%, 3 months difference. 3 to 5 months difference 0.7%, 6 to 8%, 6 to 8 months 0.6%, and 9 or more 0.4. That's very interesting. Okay, so continuing, I'm having fun with the mouse because my pen is not working. So some details now. So if you just wanted to hear the basic idea, this is it. We're done with the basic summary. And that summary is, despite a booster, there are people who still become serious. And those factors are what we just saw. Old age is one factor. Immunosuppression is another factor. Chronic kidney disease is another factor. Being male is another factor. And there was one more. So these were all so comorbidities. These were all kind of negative factors, and the only positive factor was an infection and then vaccination. So now some excerpts from this study that is very interesting. And I'll go to the study as well. I want to first go through these excerpts. They say individuals who were considered underweight, living in urban rather than rural settings, and those with a shorter period between vaccination doses. This is a very interesting one. Remember, UK was the first one that did an experiment of stretching or dilating the window between the two doses. So here, a shorter period between vaccine doses in the primary schedule were at increased risk of severe COVID-19 outcomes. So underweight folks living in urban area, then those who were given vaccine with a shorter distance between them. By contrast, those with a history of COVID 19 were shown to be at reduced risk. There was no other situation where the risk was reduced. These observations are in keeping with the previous literature. Then look at this. I want to go down here to Moderna versus Pfizer, then go back up. So look at this one, Moderna and Pfizer. Individuals with a history of SARS-CoV-2 infection, infected more than nine months or more before the booster dose versus no previous infection, were found to be at reduced risk of severe COVID-19 outcome, 0.38. And I wrote 0.41 because that was in their abstract, but here if you see 0.38, even better. The risk, now check this out, the risk of severe COVID-19 reduced after receiving the booster dose. That is, now look at this, 9 weeks after mRNA booster versus, so you got the booster and then there are 9 weeks after, versus 3 to 9 weeks after primary. So primary vaccine series, then 3 to 9 weeks after. So what is happening during that time versus booster and then 9 weeks after. The adjusted rate ratio was 0.54. But if you look at the Pfizer BioNTech, 0.80. Moderna reduced the risk 0.54 and Pfizer 0.80. Pfizer really did not hold up very well. Okay, so now if I go back here, they say that our data suggests a lower rate of severe COVID-19 outcomes in people who received Moderna compared with those who received Pfizer. Then they talk about short-lived protection. Our observation of increased risk 10 weeks after primary vaccination is supported by previous work. I think we all know that, which showed that peak antibody response was seen in the first month after vaccination, but then declined almost fourfold over the following 10 weeks. And we have done those discussions that within 10 weeks, it just went down. They're being very kind to say fourfolds instead of actually giving you the right numbers here. Kind to the vaccines. Similarly, now check this one out. Similarly, post-booster antibody responses. So, of course, the antibody responses are going to increase when the booster is given. Post-booster antibody responses have been shown to peak, but immune waning then occurs rapidly, with one study reporting a 5.5-fold decrease in peak antibody titers within 16 weeks. Within 16 weeks. Again, very short time. This is 4 weeks, right? Sorry, 4 months. So booster every 4 months or even shorter, because some of the protection actually stopped becoming protection after 1 month. So if you go back there with the infection and booster, you'll see that. But anyways, they're invoking a different study to say, hey, that study said 16 weeks. Because we did not have access to serological data within this study, we could not determine if individuals with specific clinical risk factors mounted a full immune response after a booster. So they say maybe there's a limitation because we didn't actually have the blood samples to look at the sero prevalence. We cannot, maybe people just did not mount the right response. And then they invoke another previous study and they say a previous study has reported suboptimal immunological response across many of the groups identified in our analysis as being at increased risk of severe COVID-19 outcomes. So they say more studies need to be done. Now, check this one out. This, I think, is very interesting. Our findings indicate a range of demographic and clinical factors associated with increased clinical risk of severe COVID 19 outcomes despite booster vaccination. Now, hear this out, and raise questions regarding future approaches to enhance protection. So if you think about it for a second, what they're saying is we are giving boosters to enhance protection. They're saying our study is raising questions for future approaches for how to enhance protection. So even when this is a study that is commissioned by, let's say, government, and it is being done for the government, and hopefully they're looking at the data and doing a correct, good study, but they still, when it comes to their commentary, they still are raising this flag to say, it seems like we should look for more ways to protect. Increased clinical risk within older people is not unexpected and is likely to reflect underlying frailty, comorbidity, and immune senescence, immune cells becoming old. Indeed, this pattern is seen with other respiratory viruses despite the introduction of novel adjuvanted, adjuvanted vaccine formulations. So, for example, flu, let's say. Flu has a different mechanism, but still, flu changes as well. That changes in a different way, but it changes. There is a similar situation with the common cold viruses, coronaviruses here. I think we are struggling with a virus which isn't very prone to getting vaccinated and just leaving us alone. Although, as we all develop our immunity, will become better and better. But that is a struggle you're seeing here. So then they say immune senescence is a feature common to several risk groups and indicate that despite strong immunogenicity, current COVID-19 vaccine cannot deliver equivalent protection to all individuals. This is a very important statement here. Let me actually show you the authors or their associations. Utkarsh is University of St. Andrews. Stuart is Swansea University, all UK universities. So here, Colin, University of St. Andrews. Jason, Department of Primary Care Health, University of Oxford, and so on. You can see the rest here as well. So the point is, there are many researchers here from many universities because they were covering all the four nations. So many universities came together, pulled this data, millions of people, and here they're saying current COVID-19 vaccines cannot deliver equivalent protection to all individuals. So maybe delivering protection, but not equally good for everyone. Future approaches should aim to improve vaccine immunogenicity. This is a very interesting statement here, and involve a range of novel strategies. So, do you know who in the US in the mainstream has started to say that, hey, we need to think about it? The Al Ali from the Veterans Affairs Hospital, who's done a lot of studies, I would say at par with the Qatari studies, he has been saying this as well, that we need to look at our approach once again. So here they are saying too, future approaches should aim to improve vaccine immunogenicity and involve a range of novel strategies, including variant specific immunogenic agents, introduction of viral proteins in addition to spike. This is very interesting. This has been said for a long time that, hey, why only spike? Why not other parts of the viruses in the vaccine as well? So that's what they're saying here. and the incorporation of immunodominant cellular epitopes. So, how about other epitopes that are immunodominant? However, these approaches are unlikely to overcome immune suppression in the most vulnerable group. So, they're saying that this is not going to happen, that you make all these changes and the groups that are immunosuppressed would somehow magically become better. They will not, they would still be at risk. For that reason, additional approaches such as administrations of anti spike monoclonal antibodies and antivirals should also be considered. So, very interesting for me to see a mainstream study looking at the data. So John has a comment here. John says, I think probably some N protein, but N protein is probably toxic. Yeah, so N protein, as you have been pointing out for some time as well, that itself is toxic. And the study, remember a few days ago, last week, I think on Friday or Thursday, I discussed this study where spike protein causes endothelial damage. In that, because they were not just talking about the spike protein, they were talking about the whole SARS-CoV-2. They were also talking about N protein causing endothelial damage. So even N protein will have to be looked at more carefully. This actually puts the question in my mind, and that is, number one, there are many other um, therapies, interventions that have been discussed. Why not mainstream look at them? That is one. And secondly, there are vaccines from China, for example, I believe from India as well, which are inactivated virus vaccines. Why not look at those results as well? And then there are folks who didn't have any vaccines and performed well. Why not look at them as well and collect all that data and then see what is the right approach? So this is the discussion. Thank you very much for your time. Please like, subscribe, and share. And there are links in the description if you would like to support this work. You can get access to Dr. Bean for a very, very low price, one-time price, no recurrence. Or you can use PayPal, you can buy me a coffee, you can become part of Substack. There are many ways, and the links are in the description. Okay, so let's see a couple of questions, then we stop. Colombian Bean says, so early treatment with antivirals in a is a novel approach. So Colombian Beans, we have been in on some of these therapies, but for general bigger picture, these therapies, interventions have either been downplayed or suppressed or made fun of or attacked. I mean, it's not uh, just this simple that, hey, somebody made fun of, called, if you talked, let's say, ivermectin, you were called quack. There were people who actively went after others and doctors and ruined their careers. And look at California. California has a law that if you speak about anything against the CDC and others with your patient, then they have made the law to punish you. So interesting situation. But anyways, this is a big mainstream study with interesting questions they are raising. I think these are the questions that are present in our minds for a long time. Skyfrog says, why is it that every exercise machine ever turns into a place to hang clothes? Well, that's a good question. Meanwhile, in America says, how does molnupiravir know to only work on COVID particles? Could it act on other viral debris in the body as well? It could. So if we just talk about the viral debris, that is different. I don't think it binds with the viral debris alone. It actually works with the enzymes. So if the virus is not active and the enzymes are not active, if there is just trash, it's not going to go do anything on them. Wendy says, what about something to prevent the virus from disease? So we have been talking about this for a long time, that there can be many other antivirals that can be looked at. Okay, so with this, Once again, please do me a favor. There is another question from Salfala. Isn't the risk of COVID hospitalization and death lower for those under 80 without vaccines? The younger you are, the lower the risk. So they did not compare people without vaccine. This whole discussion was that what are the risk factors? Who are the people who are still becoming serious after getting the booster? So they compared these groups. So this is a fair thing to do, to pick up a non-vaccinated group and then stratify them and then compare them to a vaccinated and boosted group. But again, we don't have that data. We can pick up some other study and say, well, this study said this and this study says this, but a cohesive data analysis cannot be done outside of those who actually have access to this data. So one more time, thank you very much for listening in. John says, I still think Paxlovid works, but inhibiting an NSP5, not lowering viral load. So your next option says, how could mRNA vaccine S1 spike protein can go to heart and brain? There are many, many mechanisms through which it does that, and we have discussed those as well. So the basic question when you're talking about S1 or the spike protein going to various parts of the body is to first answer the question of how would the spike protein come out? And so we have discussed that as well. So with this, thank you very much. Yes, vitamin D levels are important. Cell well. Yes, knowing the level and maintaining that level is very important. JR says, did this study shine a light on natural immunity? No, so they were not talking. They did say infection plus booster had the most reduced risk of being severe. That is the only one area where they shone some light. So once again, thank you very much. Like, subscribe, and share. And there are links in the description if you would like to support this work. And I would see you either tomorrow or day after. I have a business meeting and I need to go out. If I came back in time, I'll see you tomorrow. Otherwise, day after. Thank you very much. Bye bye.